Well, thanks everyone, and it's really a tremendous pleasure to be here. Matthias didn't mention we had met when you were doing some laboratory work in the United States and spent some time in our lab on his way back here. So, and I can't tell you how many friends of mine are extremely jealous that I was able to come on this trip. So it's really a thrill to be here. Enjoy your city. So today I'm going to talk about risk prediction in melanoma. I don't have any disclosures. So I'm looking forward to chatting with you to hear about how things here are in Austria, but in the United States, incidence of melanoma and mortality continue to rise. On the left here is a graph of, this is rates of cancer incidence from 1975 to 2008. And these are limited to cancers that are increasing by 1% or more per year. And you can see the top line that melanoma has the highest incidence rate compared to these other cancers, which include liver, thyroid, pancreas, and kidney cancer, and that the slope of the increase is equal to or greater than the slopes of the other cancers. So it's really very important in that it's continuing to increase. Now, on the right is a graph of average years of life lost to cancer, and you can see that melanoma is second only to breast cancer among the major adult cancers in terms of years of life lost. So melanoma at 18.5, breast cancer 19.1, and the other more common cancers, lung, colon, prostate, are really lower down here. And the reason for this is that melanoma tends to affect a younger group of patients, so there was more years of lives lost to melanoma. Now, everyone in the room here knows that melanoma is highly curable when diagnosed early. This is just some of the data. You can see when melanoma is diagnosed at just the local stages, the 5-year survival is 98% according to the American Cancer Society numbers. And this drops off very dramatically when it spreads to regional and distant sites. So early detection is we've been saying early detection is the key. And recently, I'm sure you're all well aware, because this was a study done not far from here, in Germany, that population-based melanoma screening may actually save lives. And this, I thought, was a very clever study. They looked at the melanoma mortality in Schleswig-Holstein, and it was about 1.7 here in this time period, 1998 to 2000. And then they implemented an education program and then a screening program about 5 years later, and then looked again at the melanoma mortality in Schleswig-Holstein, and it had dropped by about half to about 0.9 here, whereas the clever part was that they didn't do a randomized trial, but they said, well, let's just look at the surrounding regions, and you can see that the shading really hasn't changed. So in the surrounding regions where there was no program, melanoma mortality stayed the same, but where there was the intervention, it did drop by about half. Now that sounds great. But it's very expensive. What's not getting shown here is my statistic that it's about 127, we calculate about 127,000 people need to be screened to save one life. And I'll tell you how we do the math. I'm not a math person, so this will be the end of the math for today. So the number needed to screen is 1 over the absolute risk reduction. And the absolute risk reduction is the pre-screening mortality minus the post-screening mortality. So if we look at Schleswig-Holstein in the study, the pre-screening was about 1.9 per 100,000 men, where the mortality was higher than in the women. The post-screening mortality was about 1 in 100,000, so again, about a 50% decrease. And what this comes out to be, to get the absolute risk reduction, is 1.9 minus 1 is 0.9 per 100,000, and 1 over that is 111,000. So 111,000 men and likewise 143,000 women would need to be screened to prevent one melanoma death. And the reason, so even though there's a 50% drop in mortality, the reason you need to screen so many people is because, frankly, the mortality is not that high in Schleswig-Holstein, 1.9 per 100,000, because melanomas, do tend to be caught fairly early. So, so this is an enormous number, and just to, at least in the U.S., nobody's going to be willing to pay for that. So, I don't know how it is elsewhere. And to just put it in context, if you look at colon cancer, which is probably the best success story for screening, you need to screen about 100 people to prevent one death from colon cancer. If you look at breast cancer, you need to screen hundreds of people, hundreds of women. And you can see here that probably part of the controversy about when to start doing screening is that you need to screen many more women between 40 and 49 to save a life. But then as mortality rises with age, which is just natural for cancer, you need to screen fewer people to save a life. But we're still talking about hundreds of women. And for men, for prostate cancer, we're talking about 1,000. So you do PSA screening, and then you follow people, and over a 9-year period in this particular study, you need to screen about 1,200 men to save a life from prostate cancer. Still sounds very expensive, but it is done. But for melanoma, we're a couple of orders of magnitude higher. So we just said, well, we'd like to conduct a study to figure out ways to reduce the number needed to screen to save a life from melanoma. Because unless we came up with a really super cost-efficient way to screen people, it was just going to be too expensive. So our strategy is to develop a risk prediction tool that could be used to help identify patients at high risk for melanoma. And then you could use this tool to select patients for, first, a clinical trial of screening to see that if I select patients using this tool, do I decrease mortality, and have I now decreased that number needed to screen? And this was done in lung cancer in the United States. They took patients and figured out their risk based on their smoking history and perhaps some other factors. And then they had them go for CAT scans yearly. And they showed a real drop in mortality in lung cancer. So it can work if it's properly implemented. So right now, our approach to risk assessment, I think everyone's approach around the world, is to look at risk factors. And I kind of draw this as like a pie. So one of the risk factors are what are in the pigmentation category. So hair color, eye color, skin color, and I've also grouped in here a tanning ability or response to UV. And the odds ratios for the lowest risk individuals, sort of the darker hair color and skin color, about 1.4 up to 3.6 for sort of the red hair, blue-eyed, type 1 skin, always burn, never tan. Another very important risk factor is environmental exposure. So outdoor sunburns, typically more than chronic sun exposure. And of course, indoor UV in the form of indoor tanning. I don't know if that's a problem here, but in the United States, it's continuing to be a growing problem. It's estimated about 30% of young girls, teenage into early 20s, to go and do indoor tanning at some point in their life, and it's an increasing problem. And it's been pretty well established that it does associate with melanoma in a dose-response way. Now, probably the most important risk factor are moles. So patients who have lots of moles or clinically atypical or dysplastic nevi have higher rates, have higher risk for melanoma than people who have very few moles or smaller moles. And these odds ratios can range from 2.5 up to about 10.5. Now, this is a table from a paper from the Minnesota Skin Health Study, which was a study of indoor tanning, and I'll get back to that in just a moment. But this is just to illustrate how what the data look like, showing that moles are a risk factor for melanoma, and then another interesting observation about this. So in this study, patients were given questionnaires to fill out, and one of them was this chart, which is how many moles do you have on your body, and you were to pick one of these. And when you look at the responses, you could see that the patients in this group here, some and many moles, were much more prevalent in the cases than in the controls, and the odds ratios here were about 6 to about 14. So really, falling into this category here really increases your risk for melanoma. And we call these patients nevus prone. This was a term derived by, noted by David Whiteman down in Australia. Now, the other group here are the patients who have a few or no moles at all. And you can see the odds ratio of having few moles is only about 3. But the really interesting thing, I think, is that the nevus prone patients only make up 28% of the melanoma cases. So if you look in this column alone, you can see this is only 28% of melanoma patients. And most melanoma patients really are going to look like this, most of the ones who come in the door. Now, we all know what to do with these people because, as dermatologists, they often get referred to us because they have so many moles and they need to be followed, and that's mostly what my clinical practice is about. And we'll put them under surveillance, and we'll catch their melanomas early. And there's actually some data that people with dysplastic nevi tend to have thinner melanomas, and I think it's because of surveillance. But we don't know how to identify here which of these patients are going to develop melanoma, because so many of them won't get melanoma, but yet it's going to be most of the patients who do get melanoma, and they're likely to be thicker. So, and these are called the nevus-resistant patients. So, so the other piece of the pie is genetics, and we know that genetics, melanoma is likely a result of a genetic predisposition and some environmental exposure, like other cancers, and we certainly know that genetics are important in moles and genetics are important in pigmentation, but it's likely that there are genes that don't have a clinically observable phenotype, and if we can discover those and plug them into this risk prediction model, that could be very, very useful, because really what we'd like to do is identify those nevus-resistant patients who are at an increased risk. So the first gene that we decided to look at in this vein was the melanocortin-1 receptor, which I'm sure many of you know about. It's a 317 amino acid long G protein coupled receptor expressed on melanocytes. The binding of the ligand alpha MSH melanocyte stimulating hormone leads to signaling for pigment, for eumelanin synthesis. But MC1R also plays a role in the repair of UV-induced DNA damage and the defense against oxidative stress. So it has more than just its pigmentary role. It's highly polymorphic. There are more than 80 variants that have been identified, especially in European populations. And these polymorphisms or variants are associated with red hair, as well as fair skin, lack of tanning ability, and freckling. And the variants have been categorized, what are called the major variants, what are called common variants, have an allele frequency of more than 1% in the population. And they're categorized as big R for red hair color and little r for non-red hair color. And that's based on how strongly they're associated with the red hair phenotype. So these variants here at positions 84, 151, 160, and 294 are very strongly associated with red hair. Odds ratio is 50 to 120. So these are the red hair variants. The non-red hair variants, the odds ratios are about 2 to about 6, and that's these here, positions 60, 92, and 163. So that's the association with red hair. When people say, well, are they associated with melanoma? And if you look at a meta-analysis which was published, the odds ratios range from about 1.2 to 2.4. Of course, we'd love to have odds ratios like this for melanoma, and then we'd really know who's at risk, but it'd be a real stretch to get to that. So, so to develop our risk index, we took the following study design. We used a subgroup of patients from this Minnesota skin health study, which I mentioned before. So this was a case control study of melanoma associated with indoor tanning. So the melanoma patients were derived from the state cancer registry, and then the control patients were pulled out of the state driver's license registry and contacted for participation. And they filled out these questionnaires about their risk factors with an emphasis on indoor tanning. Now, just to tell you a little bit about Minnesota, so it's here in the northern part of the United States, and I looked up last night to figure out where is the equivalent latitude in Europe so you can have some idea. So it's about the same as Milan, Italy. I think actually Minneapolis, which is down here, the capital, is around the same latitude as Milan, so I guess a little south of Innsbruck, right? So a little bit more sun exposure, but still in the US not considered very sunny. And very short winters, very short summers, very long winters. It's about 5 million people, 50% are female. That's about the national average in the United States. It's very Caucasian. About 87% of Minnesotans are white compared to the national average, which is 78%. And then very interestingly, the ancestry of Minnesotans is 38% German and then 32% Nordic. So about 70% of Minnesotans are Northern European derived. And in the U.S., I couldn't get the Nordic percentage, but the U.S., it's 12% German overall. So we can talk about it later, but I think that ancestry, there's genes associated with ancestry, and I think they're probably very important as well in trying to figure out the genetics of disease. So what we find here may or may not be applicable to other populations, but would be applicable, to perhaps Northern European populations. And college graduates are a little bit higher in Minnesota than in the U.S. overall. And we know that melanoma is a sort of a disease of sort of more affluent people who are working indoors and going outside on the weekends type of thing. So, so the issue of college graduates is somewhat Okay, so getting back to the study, so we collected this detailed demographic information and UV exposure history, including measures of outdoor and indoor tanning. We got germline DNA from mouthwash samples for MC1R sequencing from 1,640 subjects. This was a subset of the larger study of about 2,000. We detected the polymorphisms using a software program, and then we looked for the association between these polymorphisms, ultraviolet light exposure, and case control status, and then we built multivariable models and cross-validated them to see how well we could predict melanoma. So there were 52 ultraviolet light exposure variables in 9 categories. 32 pertain to indoor tanning. Some were even asking what kind of tanning machine you might have been exposed to. That was the original point of the study. And about 20 outdoor measures. We performed univariate analysis on all of these variables. Many of them were statistically associated with melanoma. We chose the ones for risk prediction based on statistical significance, as well as what could be an easy way to collect them in a clinical setting, because if you're going to have a patient who's going to come in, you don't want to spend time doing 52 variables. Nobody's going to do that. So we wanted to minimize the number of variables that could be easy to collect and hopefully minimize recall bias. So here are some of the results. You can see that we had equal proportions of male and female in the cases and controls. As I mentioned, this was a study of indoor tanning, so one limitation is that the upper age limit of this population was 65, because they wanted to capture enough people who actually went indoor tanning. And that's a little young for a melanoma study, so we always have to bear that in mind when we look at the data. And then our average age was about 46, so a little younger than typical. Eye color did not associate with melanoma risk in this group. Hair color certainly did. You can see red-haired patients had red-haired subjects had a risk of about 4.5, and slightly increased risk for blonde and light brown. Skin color also, the lightest skin colors were associated with melanoma, and the presence of freckles as well. You can see these odds ratios are in sort of the 1.5 to up to about 3 range. And then moles here, in this subgroup, the numbers range from about 2.5 up to almost 11 for the few up to many moles. Now for ultraviolet light exposure, sunburn, whether you had a sunburn or not in childhood under the age of 18, we thought that was sort of as a yes-no question would be easy for people to remember, and that was associated with a modest increase in risk of about 1.8. And then indoor tanning, we had 3 categories: those who never went indoor tanning, those who tanned for 10 or fewer hours, or those who tanned for more than 10 hours. And you can see here this dose response, more indoor tanning with a higher risk. And this was more fleshed out in the original study. And we kind of broke it at 10 hours to have equal numbers in the group. So really for statistical reasons, it wasn't anything else than just to have enough numbers in each group for statistics. Now here's the results of the genotyping. I won't take you through it, but just to tell you that we had these 9 common variants and assigned to the big R and little r, as I mentioned. But then the interesting thing that we found were, since we sequenced the entire exon of it's a 1 exon gene, we found insertions and deletions and rare variants. So you can see insertions and deletions more represented in the cases than the controls, as well as the rare variants. And insertions and deletions, you can imagine, we're going to disrupt the protein structure, so likely to be deleterious. And maybe that's why they're more in the cases than the controls. Now, using the conventional genotyping, you see here this is the consensus sequence, so no variants as our reference. And then we looked at each of these different genotype combinations. So whatever the variant was, we put it in the little r or the big R, and then we looked at the odds ratios here. So you can see that as you go from a homozygous little r up to a homozygous big R, or mixtures in between, heterozygous mixtures in between, that the melanoma risk increases, and that the homozygous big R has the highest risk associated with it. And these are statistically significant. Now, I mentioned the rare variants and the indels. Well, since nobody's talked about them with association to red hair, we didn't put them in a big R or a little r grouping, but we looked at them on their own. So you can see here are the rare variants with consensus. There's no increased risk if you have one rare variant and a consensus, but if you do have a big R or little r with a rare variant, there is an increase in risk. And the same thing with the insertions and deletions, even quite high odds ratios here. And one of these indels with consensus also was associated with melanoma risk. Now these numbers are very small, which is what you'd expect for things that are rare. But yet that we did have statistically significant associations. So in order to combine the knowledge of these indels and rare variants with the other more common variants, we came up with a modified scheme, a genotyping scheme, which we call big M, little m. And the reason is for association with melanoma, strong association or weaker association. So you can see here on the left are these conventional groupings. Here are the variants. And what we looked at was the associations here and the p-values. For example, when we looked at, and the little m were for things that are weakly associated with melanoma, and the big M were more strongly associated. And we end up switching a couple of categories. So the 84, the D84E, which is a big R, very strongly associated with red hair, not particularly associated with melanoma in this population. So we changed it to a little m. Likewise, this I-155T was a little r. It was statistically associated with melanoma, so we changed it to big M. And then the indels and rare variants, because of what I showed you the associations before, we made those big M as well. So when we look now at the genotyping based on the big M and little m, the numbers at first glance look pretty similar, and they are. They're only slightly increased in each category with the big M, little m. But when you get down to the homozygous big M and compare it to the homozygous big R, you can see that this is about a full odds ratio goes up by 1. So from about 3.8 to about 4.7. So we built our model using the big M and the little m. Now, I keep talking about a model. How do you do it? So we identify statistically significant risk factors, which we've been talking about, and then we put them into an equation. I told you there won't be any more math, so we're not going to talk about the equation. I didn't do that. Our statisticians took care of that. And then we assess the model's ability to correctly classify the cases and the controls. And we do this by something called the receiver operating characteristic curve. And this is a trade-off between sensitivity and specificity, kind of like a diagnostic test, if you will. And the area under the curve is what measures the model's performance. So for example, here is a typical diagram. So you see sensitivity on the y-axis going from 0 to 100. 100 being obviously most desirable, and then 1 minus specificity here on the x-axis, so closer to the 0 is closer to 100% specificity. The predictive ability is this thing we call area under the curve, and the higher that this curve can get to the upper left-hand corner, the greater the area under the curve, which we call AUC, area under the curve. So a higher AUC is a better model. So there's a busy slide. I'll take you through it. Here's our models. So the model A, which is the reference model, is basically what we call the host factors. So all the clinical things that we typically are looking at: age, gender, color, freckling, and then mole phenotype. So we put patients in either no moles or few moles as one category, and then some or many in the other category. So nevus prone, nevus resistant. And the area under the curve was about 0.72. Now, just for reference, this approach has been used in breast cancer. There's a famous model called the Gale model, and they're in the like 0.6 to 0.65 range. So our risk factors really are quite good at identifying patients at risk. If you add now the sun exposure, so the environmental exposure here, the increase goes to 0.73, and that's statistically significant. If you just take the host factors and just add the MC1R genotype, it also gets up to almost 0.73, but statistically better than the host model alone. So we can see just adding this one gene does improve the model. When you put it together, the sort of the gene and the environment and the host factors, we get up to about 0.74. Now you might say, you know, all right, you got to 0.72 to 0.74, what's the big deal? Well, that in the model business is really a lot. Like the Gale model, you know, they looked at many genetic factors, and they can move it, you know, with many of them, maybe 8 of them, and now they're trying to add more. And then if they can improve it by this much with 8 genes, you know, they're very happy. So, and unfortunately, in the funding business, the grant funding business, you have people who say, that's great, okay, we should do more of this, and then you have people who say, that's not very impressive, we shouldn't do any more of this. So people look at the same data and come to 2 different conclusions, and nowadays all you need is one reviewer doesn't like it, and you're done. So it's a struggle to move it forward, but we're still working on it. Here we have what we call the cross-validation. The statisticians basically took a subset of the patients, did the math, came up with the coefficients for the model, and then applied it to the larger group. And they did that like 1,000 times in an iterative fashion and averaged up the areas under the curve. And the important thing here is that the AUCs are a little bit lower than they are on the first go using all the patients, but the relationships all still hold. That you can see there's an increase in the predictive ability of the model moving from model A to model D. The ideal would be to have a separate population in which to test it, but we haven't gotten there yet. Now, I mentioned before early on that our biggest challenge is identifying nevus-resistant patients, right? The ones who don't have a lot of moles, who are going to make up about 70% of melanoma patients. How can we identify them ahead of time so that we can kind of figure out a screening plan for them? So we divided our group into the nevus-prone and the nevus-resistant patients, and we say, well, let's see how well the model does in helping to identify especially those nevus-resistant patients who are at risk. So you can see that when we do that, for model A, the area under the curve drops off quite a bit from about 0.72 to 0.69 for the nevus-resistant and 0.6 for the nevus-prone patients. So, you know, one of the reasons here I think that it drops off so significantly is what we did was we matched nevus-prone melanoma patients with nevus-prone controls. So you have all these moly people who didn't get melanoma, so now the effect of the moles as a weighting factor in the risk model is diminished. So I think that's why this drops off so significantly. And now, as you look and say, okay, we'll add in the UV and the MC1R, and the full model, you can see that the full model does improve the prediction in each of the subgroups, but it improves it to a different degree. There's a much greater improvement in the nevus-prone patients. We pick up about 7.5 points here from 0.6 to 0.675, whereas here we pick up about 2 points roughly from 0.695 to 0.72. So what that means is that there may be different genes that are going to be important in the nevus-prone group and the nevus-resistant group. So as we move forward with this, we want to bear this in mind. And when we test different genes, we might find that we need actually different models to maximize the predictive ability. Now, one of the criticisms is, well, you know, nobody's really nevus-prone. The nevi are continuous. You know, you have 43 or 44 or 106, you know, but, you know, for our purposes in medicine, we have to put people into categories. And we think this is a useful way of doing it. So our next steps, replicate in other populations. We'd like to add additional genetic variables to improve the model. And as I mentioned, different variables may be needed to create optimal models for nevus-prone compared to nevus-resistant individuals. Now, this is a paper just came out about a month ago. Very exciting for us. Basically, they did what we want to do. But instead of thinking that we got scooped, I said, this is great. We can go back to our reviewers and say, this works. This is a group from Texas, MD Anderson Cancer Center. They took 11 low penetrance variants from genome-wide association studies, and they put it into their model, and they showed that it improved the performance of the model. So 11 genetic variants, low penetrance meaning that the odds ratios are about 1.2 to about 1.9 perhaps. So whereas the MC1R is what we call moderate penetrance, you can see the associated risks are, you know, somewhere between 2 and 4. And these variants were found in these very large genome-wide association studies. So very, very high levels of statistical significance, you know, thought to be true associations. And you can see here that This curve here is sort of brown curve, and the other curve that sort of overlaps with it. That's the host factor model, basically, and it had an area under the curve of about 0.638. And then if you add the genetics to it, it goes up to about 0.668. So they pick up about 3 points by adding these 11 genes. Now, very interestingly, MC1R not in this model. Because of the way the GWAS were done, the initial GWAS, MC1R wasn't picked up because of just the way the chip that they used was constructed. So, and also they don't have this nevus prone and nevus resistant grouping. They just kind of lump everybody all together. So we're actually very excited that if we can get the funding to move our things forward, to look at these 11 variants in association with what we've done, we might be able to push our area under the curve higher than it is already. So a future risk assessment paradigm that we're thinking about is a patient goes to their general medical doctor or whoever and fills out this self-assessment of are they nevus prone or nevus resistant. And then you know, the cost of this genetic analysis is really falling. You can actually just spit in a cup now, and that's how we collect DNA from patients, their inherited DNA. They just spit in a cup. We can extract DNA from the cells and the saliva. And you can say, okay, you know, you filled out, you're in this nevus resistant side. Now we're going to apply our genetic model to it, and maybe we'll find out that you're low risk. So we're going to say, you don't need to be screened. And when I talk about screening, I mean, you know, come in every year and get a skin check whether you are worried about anything or not. You might say to these patients, give them some educational information. If you see a new or changing mole, go see your doctor, but you're not going to screen these people. If you come up that these people are high risk, then you say, okay, you know, maybe you should come in once a year whether you're aware of something on your skin or not, because we really want to try and capture those patients, because like I mentioned, you know, 70% of melanoma patients are going to be in this category. Now, these are the nevus prone patients. You know, they fall into one of this. We would apply our nevus prone risk model, so perhaps different genetics. And they could be either low risk, so you say, gee, you're really moly, but you don't seem to have these other genes that you need to get melanoma. So, okay, I don't really trust this so much. So you still come in once a year, you know, because we want to catch it early. You know, maybe. But maybe we don't need to do total body photos or anything like that. And you know, it's a little bit hard to say, you know, you're really moly, don't come in. But then the ones who are really moly, this nevus prone, that are high risk, you say, well, you got to come in, maybe you got to come in twice a year, and maybe we're going to do the total body photos and whatever else we might be doing, and put them under high surveillance. We know from our clinic, Dr. Kopf had published that if you look at these people and follow them for about 10 years, that about, I think it was 10% of them, you know, will go on to get melanoma. So it's still 90% who won't get melanoma, at least in a 10-year follow-up. So, you know, maybe we can somehow stratify that with some genetics. So this is what we're hoping to get to. Now, you might say, well, why do I need all this genetics? Just, I'll look at your hair color and I'll know, you know, if you've got red hair, you're the person I want to screen, or you got blonde hair. But it turns out that this is, these are the genotypes, so back to those red hair genotypes, proportions for all the subjects who had brown and black hair, right? So some of you who have brown and black hair in the audience probably have one of these variants. It turns out about 35% of subjects with dark brown or black hair, and that was the cases and the controls in Minnesota, you know, have one of these variants, you know, and 21% have one of these big R variants, which were the more highly associated with melanoma. So just looking at hair color isn't going to cut it. You gotta know the variants. Now, you might say, okay, fine, you get this risk score, you tell the patient, you know, you're at high risk or not, you know, is it really going to affect their behavior? And honestly, I don't know, but they asked that question in France, and they, this was just published. It was, sorry, I don't have the citation here, but they conducted the study in 2011. They took, and this was in the Primary Care Family Medicine Journal or something like that. They took 20 primary care practices that are located on the western coast of France. All patients completed a self-assessment risk questionnaire to calculate a risk score. And I looked at the questions, and I don't know if they had too much about moles or not, but they had things like sun exposure and some of the more routine types of questions. And then they put them, and they said, look, we're either going to call them high risk or not high risk. And we're just going to give a sort of, not going to be anything in between. And after they completed this, they were randomized to a physician examination and counseling, or just sort of receiving pamphlets, in the waiting area with no exam and counseling. And then they looked after the summer in a telephone survey to see if their behaviors were any different in the group. So the intervention group was less likely to sunbathe, 25% versus about 40%, barely significant statistically. I forgot to mention there's about 176 people altogether in the study. And the intervention group was more likely to conduct a skin self-exam, about half of them versus about a third of the control. So the point was that actually talking to the doctor and having the doctor review the reasons why they were at what was considered high risk actually did seem to have the potential to impact patient behavior. So in conclusion, patient self-reported risk factors can be combined into a population-based melanoma risk model with a good predictive ability. Adding MC1R genotype and UV exposure variables resulted in significant increase in the performance of the model for both the phenotypically low-risk nevus-resistant patients as well as the higher-risk nevus-prone patients, and that we, of course, need additional studies to bring this approach to the clinic. So I just want to acknowledge the people who did the work. In our group, Lauren Smith is a melanoma fellow, worked with the statisticians to do the model building. Elise Eng was a medical student at the time, now one of our dermatology residents. She did all of the sequencing analysis. Our biostatisticians, and then from the University of Minnesota, Deanne Lazovich, who conducted the Minnesota Skin Health Study, and then Marianne Berwick from the University of New Mexico, who basically helped to collect the DNA and distribute that to us with her staff, so we could do this. And I will leave it there. I'm happy to take questions. I'll just show you about a picture where I'm from. So thank you very much.